Oops.
Let's give it one more minute, because I know part of the reason we start at 10 after is to try to start on time. It's like more people are doing it. Okay, well, why don't we start? Our presentation today is from obviously a member and one of the founders of the Ancestry and Diversity Working Group, as well as collaborators. So Alice is going to talk about a project that she also presented at the American College of Medical Genetics, and they're looking for additional feedback as they get ready to write this up for publication. And so Alice is now a faculty member at the University of California at Davis, as well as collaborators, as you can see on the screen, who both are at Invitae. And this is an interesting project directly related to ancestry and diversity. So with that, I will sort of turn it over to Alice. And as always, feel free to put questions in the chat as you think about them. And we may, depending on if it relates to something specifically being said, we can take them at the time or wait till the discussion at the end.
Thanks, Sharon. And yes, to echo what you just said, please feel free to ask questions throughout. This is definitely a work in progress project. We presented a poster at ACMG, as Sharon mentioned, but we are looking for feedback, and we want to sort of spark discussion around what we've done here and kind of how best to frame it. And then just, we'd love to hear any questions that you have about sort of what we did and why we did it, and also how to sort of interpret and present the results. So really hearkening back to originally this forum was called a journal club, and the idea was for people to present sort of works in progress and get feedback. So that's sort of the purpose of today's presentation, and it's by no means a finished. So the title is Reliability of Clinician Entries for Patient Self-Identified Race, Ethnicity, and Ancestry in Clinical Genetic Testing. And this actually didn't end up being our focus, this idea of reliability of clinician entries, but I'll talk about that more in a moment. I did want to start off by acknowledging that my work personally is based in California, in Sacramento and Davis, on unceded lands that were stolen from Native peoples to form the University of California campuses. And I humbly acknowledge and honor the original inhabitants of these regions who came before the colonizers, whose harmful actions I have benefited from. I offer reverence and gratitude to their descendants for upholding the ancestors' traditions and stewardship. So the Nisenan peoples in the southern Maidu to the north of where I am now, Valley and Plains Miwok to the west, the Potton Winton peoples and the people of Wilton Rancheria, the Cochil Dehe Band of Winton Indians of the Calusa Indian community, the Quetzal Dehe Winton Nation, and the Yoche Dehe Winton Nation. May the messages we share with one another today inspire courage to sit with discomfort and examine our assumptions, gratitude for our privileges, humility in our colonized perspectives, openness to ancient and indigenous ways of knowing, and a commitment to being trustworthy partners in research. So as you may have noticed, names are very important in American Indian Alaska Native traditions, and how people are described and what we call them and what we call each other and ourselves really matters. But as most of you know on this, in the United States, the population descriptors, so to speak, that we use in biomedical research is often tracking with what the Office of Management and Budget and the Census Bureau decide are the appropriate categories for the US Census. Now, for those who haven't been following along, the Census Bureau is actually undergoing a major shift right now in how they are approaching some of the categories. So I encourage you to look into that. And there is an open comment period until April 12th that they're asking for people to comment on the current census categories. There's an open call through the Federal Register. So if the working group is interested in doing something like that, would highly encourage you. And there's also a few town halls a couple weeks back. So if anyone attended those, It'd be great to hear your thoughts on that. So as most people here know, and this is review, you've probably seen this slide before if you've seen me give talks before, there's conceptual overlap between race, ethnicity, and ancestry, and in the terms that we use to sort of describe populations in the US. And the history is that originally Congress really was trying to do something good by putting in an accountability measure for who was included in biomedical research funded by the NIH, by requiring that researchers report back on who's in their studies based on the census categories. That was in 1993. And it was a sort of a joint move by the Women's Caucus and the Congressional Black Caucus to sort of track and improve diversity in research studies. But ultimately, the goal has the ultimate result, I think, has been that people are sort of inappropriately using these categories, and now we're in this kind of sticky situation where medical records and forms across clinical care have some subset, typically, of these categories or others. And as hopefully everybody knows as well, the National Academies just completed and released their report of the use of population descriptors in genetics research. But from the beginning, when Vince Bonham from NIH came and presented to the Institute and Diversity Working Group leadership before this was sort of officially announced, he made it clear to us that the scope was really limited to genetics and genomics research, that the report could be used and applied in other realms, but that they weren't going to really touch on clinical genetics. And so there was still a space for us to continue our work, trying to build the evidence base to motivate descriptors and how people are thinking about them in clinical genetics. This is through the working group. And when we ask people what type of information they use about their patients, the vast majority said that race and or ethnicity is reported to them directly by a patient. 18% said that this is recorded by another care provider, possibly without asking the patient directly. So even though, a lot of folks are thinking about genetic ancestry, and maybe people who are doing clinical research are inferring some genetic ancestry and trying to look at how that might function in a clinical setting, that's really not the standard practice right now. So it still is pretty important to understand what's going on and how people are using these self-identified descriptors in clinical genetics practice. So on the right here, these are screenshots from 10 different clinical labs. This was a while back, so it'd be really interesting, I think, to see how some of the clinical labs have changed their forms. For example, on an LC Hub conversation series, one of the presenters, our Laura Duclasio, who's here, talked about changing the forms, and I'll just forward to that here, talked about revising the clinical lab requisition forms at ARIP labs. And then we had Anna also talking about changing their clinical lab requisition forms, not necessarily on this particular question, but just sort of the effort that they went through to do that. And this LC conversation series that was sponsored by the CIRA, the LC Hub CIRA, really enabled us to partner with them and do a deeper dive into these population descriptors, specifically on clinical lab requisition forms, and consider what's the type of information that we need, how is information being used, and sort of how might we go about changing them. So that's the realm and sort of background of what we're trying to do here. And there are different ways of thinking about population categorization. The one that we're focused on here, there's lots of questions here. You can sort of read them, and I've presented them before, but the ones that we're really focused on is how are the data ascertained? So are there particular frameworks or categories or ways of asking questions that we're going to get the best information, that we're the best type of information that we can? And then, this last question I think is really important as well to consider, is whether participants or patients have the autonomy and the agency, and whether they feel safe enough. Sorry, I don't know what's going on with my slides here. Whether they feel safe enough to self-identify in the way that they really want to and that they feel most comfortable. So we had a very cool use case that was sort of presented to me by collaborators at Invitae. This is Anna Morales and Dee McKnight. And they said, we have two forms of patient race, ethnicity, ancestry. We have this test requisition form that's filled out by clinical staff or providers, whoever's ordering the test, presumably. And this information could come from directly from the patient or from the patient's medical record, or sometimes just by looking at a patient without asking them directly, as we learned can happen. We're not sure. We don't have information about how the data on the test requisition form, or we call it the TRF in this for short, was actually ascertained, but we have that in that format. And that's multiple choice. And then there's this other with a fill in the blank. There's also this patient portal that was acquired by Invitae at some point, I think somewhat recently, the Patient Insights Network. So this is a patient-facing platform where they can log in, they can fill out the information on their own, and it's not necessarily in a clinical setting or in a conversation with a provider. So there are these multiple choice categories with an other, but there's no open-ended option with other. And then there's this ethnicity sidebar, Hispanic or Latino or not Hispanic or Latino. So at first, our idea was to sort of treat this patient portal as the ground truth. And we spent a lot of time, Anna can talk about that, and Dee's not here, but she's excited to hear about our feedback on this as well. Our idea was to treat the patient portal information as sorry, I don't know what's going on here, as the sort of what we consider to be true. And the original thought was actually to do an ROC curve. And I tried plotting some of these things, but the problem was, and this was actually pointed out to me by a philosopher colleague, Mark Fadick at UC Davis, that you can't actually, there is no ground truth, because what someone says they are in this setting and what somebody else observes about somebody's identity in another setting, that the compendium, all of those things together make up what that person's identity is. And you can't really split it apart and say that one's true or one's not. So you can't really do a true ROC curve. So we kind of went away from that. But the idea here was to actually combine what was in the patient portal with what was on the test requisition form. And sort of treat that as the ground truth. So we eventually got there, but initially we had this idea, right, that the patient portal was the ground truth, and then we would sort of test how well did the clinician or the provider or whoever filled out the test requisition form do at representing what the patient said that they were. But there is this problem, there are many problems, but the conceptual problem.
Alice, I think we've lost you. I don't think it's my internet, because I see other people moving.
Yeah, I also can't
Yeah,
hear.
it's Alice.
Yeah.
Alice, maybe turn off your video if you can hear us.
Yeah, no.
Sharon, do you want to text her? I don't have her number.
Yeah,
and let her
I
know that
can text her.
I just texted
I'm
her.
sure she thinks we're all hearing her.
Well, it looks like her program quit, so.
Yep. Thanks.
So Alice, you're now back, but we lost you, and we had lost you once before, but just briefly. I would try having your video off, or you can also have Zoom call your cell phone, which is often a more reliable audio, but.
Yes, that's a good idea. I will do that right now, just in case we get disconnected again. Sorry about that. Where did you lose me?
I mean, basically, we lost you just in discussing what approach did you decide to take once you got, past the ground truth idea. I mean, Essentially it
If
is,
you are
but it's not
satisfied
an
with your
ROC
message, press
curve.
1 to listen to your message. Press 2 to erase and re-record. Press 3 to continue recording where you
Yeah,
left off.
that's
Press
not right.
4.
Does the Zoom allow you to call your cell, or you have to
Yeah,
enter the phone number?
Sorry, I did that, Sharon, and then I don't know, maybe Zoom is glitchy because I was having it call me and then it said call accepted, but I'm not getting called on my phone. So this is very strange. Anyway, let's just,
Okay, but I would turn off your video then.
okay. All right, I'll stick
Okay.
with that. Thank you. Sorry. So you said you lost me on this slide.
I think you were somewhere on this slide, but I think you had pretty much finished what you were going to say. So I would just probably move on.
Okay. The bottom line with this slide is that it was challenging to map across the different data structures because one has this open-ended category and the other one does not. So, and the categories that are multiple choice themselves do not necessarily.
Well, and the categories don't match. There are a lot of categories on the TRF that you don't give the patient, right?
Right. So you see more categories here, and we'll look at that in the next slide as well. So there are these.
And those categories come from the history of doing recessive testing. There's certain genetic conditions that are in the French Canadian and things like that. So.
Right, but we sort of pick and choose, right? We don't have like a list of all founder populations in the US, you know, and then it's not like these categories are very specific, right? You have things like Asian, which is more than half the world's population. So it's, you know, the typical issues with using the OMB categories for things that they weren't, you know, really intended to be used for. And then, yes, then there are these more specific, you know, founder populations that probably have some particular purpose for being there. But we couldn't map these from the test requisition form or the TRF to the patient portal because the patient portal didn't have those categories. And as I mentioned, there's this open-ended text box on the TRF that's not on the patient portal. So that was sort of one limitation of what we did, but we were able to map at least most of the OMB categories. There were some differences in how they were written. This one was Hispanic or Latino, so we went with Hispanic as the harmonized measure. Native Hawaiian or other Pacific Islander, I know, is somewhat controversial since folks don't necessarily like being lumped in together. But since this is presented as a subset, Native Hawaiian is a subset of Pacific Islander, that's why we went with Pacific Islander for the harmonized. Also, since Native Hawaiian wasn't listed here in the TRF, so we didn't want to impose that. And then the white Caucasian, we dropped the Caucasian for obvious reasons, but also because it wasn't here in the patient portal. So this is our sort of harmonized set of categories that we could compare across the TRF and the patient portal to see how many of them matched. As you know, one of the challenges in this space is sort of representing the demographics in a more nuanced way that allows for multiple identities for a patient. In this case, we're looking at the majority, about 80% of our study sample, 3,686 individuals who had just one unique category. And by unique, I'm saying that here to say that perhaps they had one category listed on the TRF and another one listed on the patient portal, but those really are unique. They're the same concept versus if they had two categories and they're sort of distinct. So one unique just means maybe they had two or three, but that if they meant sort of all the same thing, then they're harmonized together. So in this case, these are people who just had one category total, and they matched between the test requisition form and the patient portal. So here's what they are. And then these are our numbers and then percentages. And this pie chart is relative to, it's among the individuals who just had one category. So not 86% of the full sample is white, but 86% of those with one category identified as white. And you can see the breakdown of the other categories here as well. So we still haven't quite figured out how best to represent people's multiple identities, but this figure here is meant to show among the individuals who had full agreement in their categories between their portal and the TRF, what proportion of those had one category, two categories, or three categories to describe them. And then that's broken out also by a given. So given that you have one of these categories in your list of unique categories, what proportion of those people, for example, who had Black or African American in their list of unique categories had just one, that's in blue, had two categories, or had three categories. And this is assuming that there's full agreement between the patient portal and the TRF. Sorry, not assuming. This is, we observed that there's full agreement between those two. And these are the numbers, Sharon, that was on your request, sort of to actually be able to see how many people actually had the different numbers of categories. And this is, again, assuming that there's full agreement between them. So the main takeaway here, I think, is that if you have Black, African American, or white in your list of categories, you're probably most likely, and Asian, you're probably most likely to just have that one descriptor. Whereas if you have Pacific Islander, Hispanic, Ashkenazi Jewish, or American Indian or Alaska Native, you're more likely to have two categories to describe you, and American Indian Alaska Native is the most likely proportionally among all of the groups to have three categories.
So of the people who have Black or African American as the only category, what proportion agree, or these are already the ones who agree? So
these are already those who agree.
Okay.
So we're still in the universe of those of this is sort of like among those who agree.
That's all this says is
category.
3.2%. So that doesn't tell me what percentage of the people who say African American agree across the two platforms.
You're right, and well, it shows you what proportion that say Black or African American, if given that they have one category, and given that they have two and three. But you're right. I guess we would need the problem here is that if you're identifying somebody by just one of the categories that is used to describe them on either the TRF or the patient portal or both, you're sort of slicing up a person's identity and just looking at that component of the identity. So this is the philosophical conceptual piece.
Yeah, no, I just meant of the people who only selected one, right? You've got,
yeah.
I mean, the data's sort of here, it just doesn't quite give you the proportion. The other thing is, it seems to me that the patient portal forces you to have more than one category if you're Hispanic, because it's a separate question, right? So
Yeah,
that's not too surprising that it's going to be high.
That's true. However, I will say, I think there are about 73 individuals that just had other.
Right. Well, right.
So I think that it could be that that folks who were sort of, as you say, forced to select Hispanic and then some other race, like they were checking other for the race question and then putting Hispanic in the secondary, sort of the drop down for the portal. So Sharon, could you share again just what would you like to, what do you think would be helpful here to see that we're missing the total purport, sort of given that someone said they were, say, for example, Black or African American, what is the...
Well, you said these are the full agreements.
Yes.
So just pick one, pick the self-reported of people that only selected white, what proportion only selected white on the other, and for Black and for Asian. I'm sure the numbers are very high just from looking at this, but it might be helpful to know. But I would just keep going because I know you have a lot of other data. So.
Okay.
Alice, maybe if I can make one quick comment.
Sure.
As I'm looking at the categories and I'm thinking about like the precision of the boxes that are available, and even if I were to double click on Black or African American, like even within Black, like it's not heterogeneous. You may have people who are of Jamaican descent. You may have people who identify as like West African, like various countries across the continent. So I'm just kind of looking and I don't really see those options available. So I'm just kind of wondering how that impacts the distribution of responses as well.
Yeah, absolutely. I mean, I think that that's one of the main critiques of the use of these categories in the first place, is that they are not precise or, necessarily informative in the way that you would want them to be for this use case, right? And so is your question, Altavis, to what extent the lack of representativeness in the categories is impacting how people are self-selecting their categories?
Yeah, I don't really have a question about it. I just I look at what's available and I'm not surprised by the distribution, because I don't really think there are specific or granular enough categories for some of the groups to self-identify or self-select. Yeah.
Yes, totally.
Yeah, I think a limitation of the study that you're going to have to deal with reviewers is that it's the patient portal that didn't give them the option to describe themselves, right?
Right.
So I think that, that sort of gets on Altavis's point, which is, unfortunately, it's the clinical side where there was an other and you could add text. There wasn't on the patient side. It was just other. So,
Right. Right.
that limits a bit what Altavis was saying in terms of understanding how people would self-describe themselves.
Yes, completely. So that was what we originally thought, that actually having a fill in the blank option on the test requisition form and not in the patient portal would mean that we might see some things that were coming up in the TRF that wouldn't be on the patient portal. And we did see that to a certain extent. So now we're in the universe of where there was a mismatch, or where there were multiple mismatches in the categories between the TRF and the patient portal. And for these higher numbers, and by the way, this is using those same 7 categories that we were actually able to harmonize across the 2. So we're looking at apples to apples here. So for 6 and 7 numbers of unique categories per person, on average, you're missing mostly things from the patient portal. So this is where there are things being added by the TRF. But if we have 2 or 3 unique categories that were attributed to an individual, actually the TRF is more likely to miss categories. So what that was sort of surprising. Sorry about this. I think it's my external mouse here. So what you're seeing is that you actually are missing, people are putting in information, they're checking multiple boxes, let's say, in the privacy of their own computer on the patient portal, that are not being shared with the provider, or it's just being missed because the provider is not talking to the patient, or they're dropping something off. And just anecdotally, something that I thought was kind of interesting is that one of the main categories that is missing from the TRF but is present on the patient portal is white. So a patient will put white and something else, but the TRF will just say the whatever the other category is. So I think that that's sort of an interesting thing to note. Any questions on this one? I'll pause for other questions.
I think when you explain what you're graphing, it's clear what you explain. I'd be curious, because Alice and I spent a while on this at the poster, is it obvious to someone just looking at this graph what's being graphed here?
Yeah, that'd be great feedback. I mean, any ideas that people have about better ways to represent this information, we're definitely, interested. Or just feedback on whether this works or not, as far as explaining multiple axes of information in one visual can be sometimes more confusing than helpful.
And what does poly refer to? You mean it's a polynomial distribution, or?
Yeah, this was just to give us some way to guide the eye to look at what's happening with the orange and the blue bars. So the missingness among TRF and the patient portal. And this was just the the line that best fit both of them, or the polynomial. Yeah. Mhm. Okay, so this one, you may have more questions about. Again, there's a lot of information that we're trying to communicate in one figure here. Along the x-axis, you have the number of categories that were shared. So this means that you're looking at sort of matching between the TRF and the patient portal. And then this is the percent of categories missed on average by the number of categories per patient. So if you have, if you're here, then you have 2 shared categories. And then this is your, on average, 6% of the categories for these individuals with 2 that are shared between the 2 are actually missed. And so it goes up, and then it sort of asymptotes around this 4.5 or so, and then comes down. So you have this increasing chance that you're going to be missing categories as the number of shared categories between the TRF and the patient portal increase. And then you have sort of going back down, so you're less likely to miss more of these categories if you're sharing more of them. So that makes sense, right? But we're just here looking also at the magnitude, so the numbers of individuals who fall into these categories. So you see sort of the majority just have 2 or 3 matching their really smaller numbers up in these larger numbers of categories shared. So questions there? Okay, so in summary, and just to sort of wrap up before we go into the discussion, most patients in our study had just one category, about 80%, but that still means 20% had more than one, either that did not agree between the patient portal and the TRF. Obviously, if there's just one unique category, it has to match between the 2. So the minimum number for any disagreeing REA is 2 categories, because you have one from the TRF and one from the patient portal, and they don't agree. So if they have just one category, then that means they have full agreement, and that's 80%. And then an additional roughly 2% of patients had full agreement with more than one category. So among those that had a disagreement between the portal and the TRF was more likely to miss categories that were present on the patient portal. And this was sort of surprising because, again, there was that free text option on the TRF. But of course, there were some cases where people added a lot of information on the TRF that was not available in the patient portal. So differences in the data structure, or this data collection framework between the TRF and the patient portal were not the only reasons for differences in the patient REA that was recorded. And that we can tell that because we looked at that apples to apples comparison, that when the categories were available on both the patient portal and on the TRF, some were present on one platform, but not on the other. And finally, there were a large number of unique descriptors that were added to the TRF for some patients. And so this suggests we think that patients probably were engaged in conversations with the clinical staff or the ordering clinicians who are filling out the forms and giving them this information, either filling out a pedigree or some other way of doing this. This level of detail was not possible to add to the patient portal because of these, lack of granular, precise categories and the lack of an open-ended option for the free text entry. So in our discussion, we're happy to take questions or suggestions for any and all of the above here, our study design, our results, the way we're interpreting it, and then our conclusions, as well as we could discuss sort of next steps if anyone else has ideas or data sets or things that you want to see from these data that we could put in the manuscript. We'd love to hear from you. And this is my acknowledgement slide with 2 of the references that I pointed out from the Ancestry and Diversity Working Group, as well as all the folks on the working group, and LC Hub and Caesar, who've also been thinking about these issues for a long time, and of course, Invite and my collaborators. So thanks. I'll stop sharing now. I can share again if we want, but I'd love for this to be a sort of open discussion.
So if Anna's available, because I see her on the call, I do think it's important to understand who are the patients filling this out. So I, for example, order from Invitae frequently, and so we fill out the TRF, but I'm not aware when my patients or their parents, in my case, because they're pediatric, are asked to fill this out. Is this if they log in, they want to log into the portal themselves? Is that everybody gets to ask the question, or how?
That's a great question, Sharon. The patients who sign up for the portal, which is a subset, not every patient will sign up for the portal, would get an invitation to join the Patient Insights Network. And those patients will be asked to complete a profile, and that's where this information came from.
Okay. You mentioned at the end and a lot of the things that got added to the TRF, and Alice and I talked at the meeting that, typically in clinic, if we're ordering genetic testing, someone's drawing a pedigree, or they've drawn a pedigree before clinic. And one of the questions you ask is, where is your dad's side of the family from? Where's your mom's side of the family from? So I have a feeling some of that probably is coming off of the questions that got asked to draw the pedigree, particularly if it's the genetic counselor or the genetic counseling assistant who took the pedigree who enters the TRF. So, that may be one place that additional information is coming from. It looks like Stephanie's got a comment or a question.
Yeah, I was wondering what I think the thing I would most like to see when looking at all of this is what are all the free text entries that people are putting in the test form that are not available on the patient portal? Like, what other identities do people have that are missing from the standard set of collections that maybe should be there, or that are frequently used? So I would love to, when you present all of this, I would love to see that in addition to like the harmonized categories.
Yeah, I really appreciate that, Stephanie. And I can sort of share, I have like the raw data. I think probably the biggest challenge, which I did not really appreciate before embarking on this, was how was the data visualization challenge. I've been thinking about data visualization being a challenge for, things like ancestry and the genome and these categories sort of like broadly. But when you start to ask the question, which categories are those that are missing on the TRF or the portal, it's not clear to me what the best way would be to sort of illustrate that. But I can tell you just from looking at some of the raw data, which I sort of pasted into my slide so I would have it here. Some actually I can probably just share this quickly so you can see in my notes. I don't mind sharing, Anna, unless is that okay? Is there any reason why we can't share the raw data here?
This is anonymized. I wouldn't think that's a problem.
Okay. Cool. So yes, if you look here, these are ones that the portal missed, but they could have oh, sorry. No, that's portal miss. There we go. So this is added from the TRF. So you have Afghanistan, Puerto Rican, Eastern European, paternal, Northern European, maternal, Japanese, and Italian, Sephardic Jewish, Afghan, Kenya, Pakistani, etc. So you can read, these are ones that were added by the TRF. And that was just one individual. And then that you can go through, and I have these broken out by like if they were missing just one, which one was missed. And so it goes like that. So you can see sort of there are a lot of different terms that are added, from geographic terms to ethnic terms to sort of language oriented or religion oriented. They're kind of all over the place. So it's hard to both to sort of conceptualize what's missing in general, or what's added, you could say, and also to think about how to represent that visually. I think it's pretty challenging. I don't know if that's helpful or.
And I think you could just have like a box with text that like lists like here are all of the things that people say they are that are not captured in these forms. Because like I think that is a powerful piece of information to include in this study, is that like what are we missing by not including a free text form? And like for the specific use case, not just like, how do people identify, but is there important information about like that would be useful for their genetic testing that is included in this free text field that is not really being considered if we're restricting ourselves just to the standard categories.
Yeah, that's a really helpful insight. And I also think it's important to note that I don't think when they looked in, I think they looked into this, and Anna, correct me if I'm wrong, but my understanding was that they found internally at Invitae that no one was actually using these categories in their genetic testing interpretations. Was that right?
Are you referring to the uses of the lab in general as an entity of the different categories? In that case, when we did an investigation and asked our different stakeholders, it turned out that for interpretation of genetic tests, it's not used. It's agnostic to race and ethnicity. Of course, we look at NOMAD, we look at the race and ethnicity categories there. I think this was in our poster, right? That the only reported use case of race and ethnicity information was for billing, because there is a code for Ashkenazi Jewish.
Right, and that is one of the arguments, because there's several cancer codes. If you're Ashkenazi Jewish, you can meet a different family history of breast cancer criteria. And that actually came out of our original study, the survey, which is that labs don't use it. They're going to classify the variant. I would say the other time it comes up is carrier testing. So if someone had selected like French Canadian or something, they will still, I mean, and that's what actually your chief medical, or your prior chief medical officer, now CEO or whatever his title, whatever Bob Nussbaum's title is, talked about how people would calculate what's the percentage likelihood you miss something, but that's sort of prior forms of genetic testing. Jen?
Right.
Yeah, following on to Stephanie's point, which I really like, I think it would be interesting to see, because one of the two categories, right, that seem way broader than they should be are African and Asian. As you said, this is most of the world's population. And then if you think about those two categories, historically, the Asian populations might actually have a lot more information about exactly what their ancestry is. And then if you think about genetic utility, the diversity of African populations makes that perhaps a more useful piece of information, but information they might not actually have. So it would be interesting to see how, if you look at what is all the information we're missing, how much of that comes through and which of it would be in fact useful.
And Terry, just what is that YouTube link?
Oh, it's from Kulu.
I hope you're as
It's
excited as I am.
they're talking something about Reservoir Dogs. It's from him. He was relating it.
Okay.
So I haven't looked at it. That's why I said it.
Yeah, no, I know. I just,
Yeah, not sure.
I've seen this TV show. It's from an episode of a television show called Reservation Dogs, which is like all indigenous made TV show. It's very good, and it's a scene that's like kind of poking fun at land acknowledgements a little bit.
okay.
Yeah, so
All
I
right.
think he's just trying to,
Okay.
make us all aware.
Okay. Bimo, sorry if I apologize if I pronounced that wrong.
That's fine. And so I'm actually going to apologize. I missed the first couple of minutes of this coming from a thesis defense, but I guess I'm kind of a simpleton. And so the figures convey a ton of information, but if, the manuscript format permits it, it's like some very simple statistics or figures may help with interpretability. And I think this gets just what I heard Sharon getting at, which is even if you can pick out one or two sort of discrete questions that are that you think are relevant. So for example, of folks who checked the Black or African American box in the portal, or vice versa, pick one as your denominator, the percentage of them for which there is actually 100% concordance or something. I get that it totally steamrolls over all of the nuance that you just presented. But I think there's actually some value in answering discrete questions that people might have as they hear about this, even if you can then go on to like tease out all of the nuance. But I would advocate for some simpler figures, or, a table that flattens the data to the point of where even like a dumb clinician like me can understand what you're saying.
I think that's a very important point, Bimal, because what I think this project is doing is highlighting the social sciences debate of realism versus constructionism. And I believe that right now the work has focused on the constructionism side, how people identify, how they act, how they relate to each other. And you're pulling towards realism. I think both sides have value, and we should actually engage in that debate and have a paper that addresses both sides.
Well, and I think one of the questions going into the study was how often would people self-describe themselves in a more complex way, like check a few boxes, and versus the TRF. And unfortunately, you're a bit limited because you don't have that other ability, although at least you could say, and it turns out it's not that high, right, that people often do self-identify with a single category. Similar, and there is some emerged data, I think, on this about that even if people's genetic ancestry suggested a complex background, that people often selected one identity. So, I think there's a lot to learn there. Mildred, maybe we'll give you one of the last questions or comments.
Yeah, thanks. Yeah, I was just, just drawing on something you said earlier, Alice, and what you just mentioned, Anna, and the National Academy's report, which I realized is not really relevant to clinical stuff. But one of the recommendations that they did have was really to think about when you could just eliminate using the categories altogether. And I think, Anna, you talked about, the fact that in most situations, people are not using all the categories, if any, and they don't need them. So I know we've probably talked about this a long time ago, but I just wanted to kind of put it back out there that this might be an option, right? Like if you're using it for billing and there's only certain categories that are very specific that you need it for, then maybe that's all you need. Because I think that there is some hidden harm in using categories for purposes that they were clearly not designed, as you said, Alice. They were not meant to be used that way. And yet when you do use them that way, it reifies the categories. And, so it's not neutral to use categories inappropriately, it's harmful.
Well, I think that might be a good way to wrap up. Alice, any last comments or Anna?
Yeah, I just definitely want to echo what Mildred just said and say I completely agree, and also appreciate the comments and the request for a more sort of straightforward statistics, and just appreciate that the folks are understanding our desire to stick to the nuance, at least for at least have a component where we're sticking to the nuance in our paper, because I agree with Mildred that it's not neutral to use categories to describe people that are not relevant, and yeah, seeing in the chat they need to get it covered by insurance, right? And I do think though, at least with carrier screening, there's been this push toward expanded carrier screening where we wouldn't necessarily need to do ethnicity based.
Almost none of that's covered by insurance. It's very specific codes,
right?
Very test. But the other thing that your prior project brought up on the requisition form is that these forms are often used for all kinds of testing. And so whether these categories are used in hypertension or something else, we also have to be, careful of, which of course there's a lot of effort to get rid of them for that purpose as well. Well, I think we used up the 50 minutes. I think it was I assume you folks appreciate the feedback you got, and it's sort of nice phase to hear the data when you haven't yet gotten the paper completely together. So hopefully will be useful for that. And Clarissa, any other announcements or anything we should be making?
No.
Okay. So I did not look at next month's schedule yet. So look out for emails about that. And Mildred, we talked about trying to get, it back onto the LC calendar, the LC Hub calendar as well. So we can look at doing that. Okay.
Thank you so much. Great feedback, great discussion. I appreciate it. And thanks, Alice, for presenting and Sharon for moderating. Have a great day.
Bye.
Bye.
Thanks.